and I would like to invite Dr. Treon to tell us about or give us an update on clinical trials for Waldenstrom's macroglobulinemia. Steve?
Thank you, Bob. And just to clarify, I took the best of the series of slides that were presented here. So by all means, this is not inclusive of everything that we learned that's new in terms of therapeutic options for this disease in the last couple of days. So the first area that there's been some innovation in, and it's worth reporting on, is that of monoclonal antibodies. And I'm sure many of you are familiar with the drug Rituxan. And this was the first monoclonal antibody that was approved for the treatment of human cancer. And it targeted a molecule called CD20 that's universally expressed on Waldenstrom cells. Roughly 99+% of patients actually have this target on their Waldenstrom cells. And so the monoclonal antibodies actually are like heat-seeking missiles. They go after a particular target. And the monoclonal antibody rituximab actually goes after the CD20. So the CD20 is on the Waldenstrom cell. The antibody, which looks like the letter Y, actually comes in, it homes in, it locks in on the CD20. And then when it does that, it brings in the immune system to actually do the killing. So it relies heavily on a patient having a good immune system to work. And so the way this happens is two different ways. One way is that you see all these proteins called complement. They all look like little spaceships. But what happens is these molecules come in, bind to the Rituxan that's bound to the Waldenstrom cell, and then these complement proteins poke holes in the membrane of the cell, and by poking all these holes, it's like poking a balloon, a filled balloon. And then what you end up seeing is a rapid escape of things that are inside and the cell dies. But perhaps the way that these molecules work the best is by attracting immune cells. And these immune cells come in, again, they lock in on the antibody. And I'm going to tell you in a second why that's important. And then it's the immune cells that end up doing the killing. And so some of the innovation that has been made is to make these antibodies work better. And so one of the problems that we came to realize very early on is that you can actually give someone Rituxan with Waldenstrom's and you can get great response rates. And when I say great, about 40% of the patients can respond to Rituxan given by itself. And these responses typically last somewhere between a year, maybe a year and a half on average. There are some people, however, that can benefit with these antibodies and have even longer responses, but in reality those numbers are fewer. And so it's a good therapy, it's well tolerated, but of course it's not everybody who responds. And this kind of tweaking is really made, in terms of innovation, has been made to see if we can get more people to respond. There's also another problem associated with giving Rituxan to patients, and that is that the Rituxan antibody is 90% human, but 10% mouse. So it was actually built from a mouse antibody, and there are a lot of people who become allergic to Rituxan. In our own experience, it's about 15% of all patients. And so that in and of itself poses a particular problem. And so, as a result, some new antibodies have been produced. This here is the Antibody Ofatumumab. It's produced by Glaxo, and this has been studied by Rick Furman at Cornell University. And Dr. David Maloney, who was here, updated us on these new antibodies and included this Ofatumumab antibody in his list of new antibodies. Now, Ofatumumab is a fully human antibody, so it doesn't have that mouse part. And as a result, this has been a reason to investigate this antibody is to see if you can actually give it to people that become allergic to Rituxan. And so in Rick's study, the patients ended up getting this Ofatumumab antibody at 2 different doses, either 1,000 milligrams or 2,000 milligrams, and the response rates were a little bit higher. They were about 59%, and they were particularly better if the patient had not seen rituximab before. So it says, in essence, that if you've seen Rituxan earlier, maybe you're somehow becoming tolerant to this type of therapy. But the real take-home from this is that you can really give it to patients who are allergic to rituximab. And that's important because there are a lot of patients with Waldenstrom's who become allergic. And as a result, having these options to continue this type of therapy is important. Now, the other area that's actually of great interest is the way these antibodies interact with the human immune system. So when I was showing you the letter Y earlier, it was right side up, but here now it's the other way around. And here's the CD20, here's the Rituxan binding to the CD20, but the other part of the molecule, the bottom of the Y letter, is very important because this is the part of the antibody that interacts with the human immune system. But all of us are different. The genetics that we have that allow us to make all these different, cells and proteins in these cells can differ from one patient to the other. And there's a very critical point on a receptor called the Fc gamma R3A receptor. This is the receptor that actually allows the human immune cells to grab on to that Rituxan. And all of us make it, but we make it in a different flavor, particularly at a position that's critical to how closely this receptor can bind to Rituxan. And as a result, some of us are blessed in having, a better configuration. If you have one valine amino acid here, it allows you to better bind it, and some of us are not. Those of us who have inherited phenylalanine don't tend to respond. Now, I'm going to tell you, this is bad genetics if you're facing, a lymphoma and you need treatment. It's good genetics to have this, by the way, if you're not facing lymphoma, because, more people tend to have autoimmune problems if they have, the good amino acid in this particular case. But that's because your immune system is a little bit more active. So as a result, and the reason why I show you this is because there is now a new generation of antibodies, such as GA101, which is now in clinical trials, and in fact very advanced clinical trials, that have combined the best of all features. This is a humanized antibody, but it's been one that's been optimized so that whether you're a patient that has, the good amino acid or the bad one, this antibody allows you to bind to both different types of receptors and demonstrates an improvement over rituximab. Now, clinically, where this is going to all end up remains to be seen, because so far, this has been investigated only in patients that have other types of lymphoma and CLL, but it hasn't yet, been investigated in Waldenstrom's patients. And at least one of our hopes is that in the next year, as we've been promised, we'll finally get this new antibody for study in patients with Waldenstrom's. Now, the next class of drugs that's worth talking about in terms of innovation, and I think it was far more pronounced at this meeting, is this class called the Proteasome Inhibitors. Now, you may wonder why I have a dump truck there with WM on it, which was convenient because it's waste management, not Waldenstrom's. But you know what? The other day I was seeing Roger Owen here showing us this slide because he was out traveling and he saw Route 138. And of course, anybody would have just said it's Route 138. To him, it was the marker for plasma cells. So right away, he took a picture. This was my golden opportunity. But what I have to tell you about proteasome inhibitors is that every one of our cells has a wastebasket. The same with Waldenstrom cells. And all the proteins that cell makes, ultimately, when those proteins get old, they got to be thrown away. And so, you end up with this proteasome, which is really the big wastebasket. Now, if you poison the proteasome, if you block the wastebasket, guess what happens? All this trash starts accumulating, right? And it starts spilling out of the bucket. And eventually what it does is it clogs up the cell. And that's how this class of drug works to kill Waldenstrom cells. And at least that's one interpretation. I have to be quite honest, I think there are multiple mechanisms, but this has been at least one of the reasons why we think these drugs work. Now, the prototype for proteasome inhibitors is a drug that I'm sure many of you know about, which is called Bortezomib or Velcade. I'm sure many of you know about this drug. But at this meeting, we also heard about another drug called Carfilzomib, which also binds to the same target area on the proteasome. And we also heard about other drugs that actually poison this process, but at different points. I'm going to, for the most part, try to focus in on Bortezomib and Carfilzomib at this point. Now, Bortezomib or Velcade, I mean, it's confusing, but every drug seems to have multiple names, which are one reflecting the generic and one reflecting the trade name. But Bortezomib is a drug that's been extensively studied. We heard a lot of studies here presented, and it's been studied in many different countries. But what we know about this drug is if you can give it with steroids like dexamethasone and Rituxan, a lot of patients respond. 95% respond. You even get a lot of patients who go into what we call complete remissions. But the problem that we face is that a lot of these patients also end up with very bad neuropathy. In fact, 30% can end up with severe neuropathy. And by neuropathy, in case you're not familiar with that term, it means that you could have pain, particularly in your hands or feet, burning, tingling, so it can be very uncomfortable. And it does go away for a lot of patients, but for some patients it can be a lifetime nightmare. And in Waldenstrom's, more patients get neuropathy than myeloma patients. Almost threefold more people can get those kinds of degree of neuropathy. Now, there have been a number of different ways, to try to get away from this risk. And this is the study that we heard from the Greek myeloma group, from Dr. Dimopoulos, presented at this meeting, where they did something interesting. They started off giving everybody a full cycle, much like the way we give it. And by a full cycle, that means getting the Velcade 2 times a week for 2 weeks, and then you get a week off. But what they did is they started off that way, and then they started giving it, in weekly dosing. At a slightly different dose. But by going from twice a week to once a week, they wanted to know if they could make a difference, not only in terms of, the way the patients would respond, but also in terms of the neuropathy. Now, what we learned at this meeting is that, in fact, they got really good responses. In fact, 80% of the patients ended up responding, so the overall response level was actually quite good. And in fact, patients responded fairly quickly, about 3 months after starting therapy. But here too, though, neuropathy was once again observed, not at the frequency that had been seen with the twice a week, but nonetheless still a concern for patients with Waldenstrom's. So at this meeting, we also heard about a new proteasome inhibitor that called Carfilzomib. And here is all the blah, blah, blah about what this drug is. But to cut to the chase, what we really care about is that in myeloma patients, this drug has no significant neuropathy compared to Bortezomib. So as a result, it's been of great interest to see if it works in patients with Waldenstrom's macroglobulinemia. A footnote, this drug just got approved by the Food and Drug Administration here in the United States for the treatment of patients that had already been treated with in myeloma. And so this was a study that was presented. It's still an ongoing study. This is 20 of 30 planned patients. And patients were given the Carfilzomib with Rituxan and dexamethasone. The overall response rate, 75%. So a little bit less than what had been reported with the other studies with Velcade. And the responses actually were pretty quick. Time to response was only about 2 months into therapy. But the take-home message was that there was no significant neuropathy associated with this drug. And so there's a little bit of a trade, maybe a little bit less activity, but really at on the other side, no significant neuropathy for concern. And so this study is still ongoing and remains to be reported in its full form. Now, we also heard about this at this meeting about another new agent, and that agent is called Everolimus. The other name for this drug is RAD1. In fact, I know that there's several of you in this group here that have participated on clinical studies with this drug. And I'm going to tell you a little bit about Everolimus because it's a drug that actually poisons this pathway called the Mtor Pathway. So there's this little signaling bridge here for which a lot of signals that tell the Waldenstrom cell to grow and survive go through, and that's what the Mtor complex is all about. And so we ended up doing a study, and Irene Gobriel was actually the individual responsible for running this study, which included patients from not only the Dana-Farber, but the Mayo Clinic. And so it was a nice collaborative opportunity to be able to treat patients who had already relapsed or were refractory with their Waldenstroms. And so what we learned in that study is that a lot of patients actually respond to this drug, which is just a pill. Take a pill a day. So it's a very, very convenient drug. There are some side effects, like the platelets come down. There are some patients that get this kind of pneumonia that's actually, an inflammatory pneumonia. It's not an infectious pneumonia, but it's the immune cells thinking that there's a pneumonia that they coalesce. And there's also mouth sores associated with this, which thanks to the work of nurse practitioner Sheehy, we know how to skip this toxicity by giving patients oral steroids to take a couple of times a day. But one of the issues that does come up with this drug is that sometimes you hear the duck quack and you think, or you hear the quack and you think there's a duck there. In this case, with this drug, is that the IgM can come down, but you see this discordant effect, meaning that the IgM comes down and you're feeling good and you're saying your patient's responding, but in reality, when you do the bone marrow biopsy, you see no change. In fact, you even see the disease progressing. So we have to be, suspicious sometimes, and do bone marrow biopsies just to confirm response. And this is what we saw with the drug RAD1. But Irene took this one step further, thinking, well, this might be a problem, but perhaps if we use it in combination with other agents, we might be able to get better responses. And so in her study, which is still ongoing, she combined Everolimus with Velcade, Bortezomib, as well as Rituximab. And I'm sure there are several people in here who perhaps are on this study as well. And this is the data that was reported at this meeting, that almost 75% of the patients, in fact, had some type of response with this combination of the oral inhibitor, Bortezomib, and Rituximab. Now, not everything we heard at this meeting with novel agents necessarily translated into, benefit for patients. This is a study that came from the MD Anderson by Sheba Thomas, who actually was testing out a new drug called pomalidomide. It's actually a cousin of thalidomide or lenalidomide, both of which are very successful drugs in multiple myeloma. And pomalidomide is emerging as one of the most exciting new agents in the treatment of myeloma as well, and we heard about that from Antonio Palumbo at our meeting. And when, in fact, Sheba tried to advance this drug by doing a multi-dose study, we call this phase 1, where you start with little baby doses and you work your way up, she ran into a roadblock that at 2 milligrams, which was her second dose up, she saw a fair amount of toxicity. And what she also saw was that the patients didn't actually even respond at this dose, but remained in what we call a stable dose. So I think that was really important because, these are new agents, and it's important, even though they work in one disease, they may not work, in Waldenstrom's, which is why we still have to do dedicated trials with each one of these agents to see what their worth is in this disease. Now, Zachary talked to you a little bit about the mutation in Waldenstrom's that's been discovered. There were a lot of groups at this meeting that have confirmed this. This is a mutation in the gene NYD88, and about 90% of patients with Waldenstrom's have this mutation. But the reason why we want to get excited about it from a therapeutic perspective is because it triggers a pathway that leads to the activation of a number of different factors that make the cell grow and survive. And so at this meeting, what we did is we heard about drugs that can actually block this pathway, drugs that are currently available, but available as a research tool. They're not commercially exploited drugs as of yet. And some of them may never be because they have characteristics about them that don't allow them to move forward. But we did learn that if you could somehow poison the MYD88 or IRAK pathway, what you could do is you can shut down a lot of important proteins that make the cell grow and survive. You could actually take cell lines that are Waldenstrom cell lines with the mutation and cause them to die, and you can even take fresh patient cells from the bone marrow, expose them to these drugs, and see that they actually undergo cell death. But there is one drug that actually may poison a different pathway affected by this mutation. And so what we heard is from Guang Yang, who made a very nice presentation, that MYD88 actually triggers this molecule called BTK. And by triggering BTK, it actually causes the same kind of circuits to light up and cause the cell to grow and survive. And in fact, when you can apply this drug, which is called PCI 32765, and now it's known as ibrutinib, so you'll see my next slides where I refer to it as ibrutinib, it can actually shut down this pathway. And so ibrutinib actually is probably one of the hottest new molecules for the treatment of lymphoma. It's what we call a small molecule. It gets to the cells and it shuts off this BTK molecule, which stands for Bruton's tyrosine kinase, for those of you who are signaling aficionados and want to know these details. And so this study, which is actually open at 3 different centers, in Boston, at Stanford, as well as shortly in New York at Memorial Sloan, has actually been accruing patients. But we got to see some of the exciting new data from this study. It's very preliminary, but in fact shows you that when patients who have already been treated previously, these are relapsed refractory patients, which is what the study is designed for, that you tend to see for a lot of these patients very nice and very rapid drops in their IgM, profound improvements in their hematocrit. Here's somebody who started treatment with a hematocrit of 29, and look this, by 4 months into it, his hematocrit went up by 10 points. And you don't just see that in an isolated patient. If you look across all these different patients, you end up seeing that this is pretty regular, that you end up seeing these kinds of improvements. And it may, again, speak to the fact that it's the mutation that's driving this pathway, which is why this drug works so well. But what we also saw was something that's been seen in other studies as well. And Dr. LeBlanc brought this up in one of our discussions, and that is that you see all of a sudden lymphocytes, the immune cells that the Waldenstrom's is part of, they start zooming in the peripheral blood. You see that a lot of these lymphocytes all of a sudden are in the blood. And at least one thought is that they're starting to run, for cover. They're coming out of the bone marrow looking for cover because all of a sudden the environment in the bone marrow has changed. And certainly additional work will be required to figure out exactly what type of lymphocytes they are and what ultimately happens to them. In the last couple of slides, I also just wanted to come back to some of the work that's been done with response assessment, because we have to have a common dictionary when we try to figure out if drugs are working in a particular way, and so that we can talk to one another as clinicians to say, in fact, that we've set the bar that our drug works just as well, compared to another drug. And if you're, running these kind of studies, you want to be able to do that in a very uniform fashion. And one of the things that we learned from the last workshop is that the better the response a patient gets, the deeper the response a patient gets. This actually translates into a longer time that the patient stays in remission. And the category of interest is this called VGPR, which stands for very good partial response. It means that at least 90% of the IgM went down, reflecting a better category of response. And these patients tended to do almost as well as patients who had a complete, remission based on this particular study. And so what came up at this meeting was, can we do better? Instead of just using IgM as a response tool, can we do better? And the only thing I'm going to show you is what the glimpse might be into the future using molecular technology so we can better screen these kinds of outcomes. This is a study that Lian Zhu presented here, as well as Zach Hunter, showing in fact a new technology called PCR technology, being able to pick up the mutation, the MYD88 mutation in the bone marrow, and then following that mutation, in patients who have been treated with various types of chemotherapy drugs. And the nice thing about this kind of technology is you can pick up 1 in 1,000 cells. You can pick up one bad guy in 1,000 normal cells, and so it gives you a resolution that's far more powerful than we can achieve with the human eye looking at bone marrow biopsies. And so what we heard from Zach Hunter was, different patient populations being treated with different drugs, and this is just 7 patients here that was shown, in fact showing that the amount of bone marrow reduction paralleled the degree by which the MYD88 mutation level also went down in the bone marrow. And so in good time, this could turn out to be a better response assessment tool, but we really do have a long way to go before anybody can make any claims on that. So the take-home message from the novel therapies and response front is that there's a lot of new options available to us. Some of these still need to be better categorized. We have the Ofatumumab antibody now, which I think can be used in patients, particularly based on our current guidelines in people who may be allergic to Rituxan. We still need to know about the value of GA101 in Waldenstrom's. We have actually new proteasome inhibitors, including Carfilzomib. We have actually the drug RAD1, which poisons the Mtor signaling pathway, and we also have the Bruton's tyrosine kinase inhibitor, and all of these are drugs that need more vetting in patients with Waldenstrom. So I would encourage you, and I think all of us would agree, if you have the chance to be on a clinical trial, participate, because that's how this kind of progress can be made. We know that some of the RAC signaling inhibitors that we studied actually show activity, but that doesn't necessarily at this point in time mean that we have a drug that we can bring to clinic. That's exactly the kind of work that needs to be done. We've now seen a new criterion for response, being that of the VGPR, which has been adopted by our panel. And then finally, molecular testing may in the future help us, not only from a diagnostic perspective, as Zach Hunter alluded to, but also from a response assessment. And with that, I will just stop and thank you for your kind attention, but also thank the sponsors who made this workshop also possible. Thank you very much.